This conference will now be recorded.
Okay, Tracy.
Good afternoon and welcome. This is Tracy Morton. I'm a Senior Program Manager here at the National Rural Health Resource Center, and welcome to the TASC 90 webinar. The purpose of our webinar is a quarterly topical presentation for the state flex programs throughout the country. We hold this webinar focusing on a variety of different hot topics of the time, and for today we're going to be talking about value-based healthcare models. I'd like to review our agenda for the day, and then we'll get started into some updates and then into our content and discussion topic. We have been recognizing changes that have been happening in the healthcare environment, and so that's why today's topic will be on value-based healthcare models. This webinar is being recorded for those that aren't able to participate in the live event, and the recording is placed onto the TASC website. That web link will be mailed out via email to all of you after the call, as well as an evaluation, a short evaluation or assessment for you to take, letting us know your feedback on today's webinar as well. On the agenda for today is a short update here from the Technical Assistance and Services Center, which is the Technical Assistance Center established by the Federal Office of Rural Health Policy to support the 45 states in the FLEX program. We'll also receive an update from the Federal Office of Rural Health Policy from Kevin Cheney, and then an update on critical access hospital regulatory issues from Aaron Fishbach with the Federal Office of Rural Health Policy. Mark Holmes from the North Carolina Rural Health Research and Policy Analysis Center at the University of North Carolina at Chapel Hill, which is a partner in the FLEX monitoring team, will be providing a short update about FLEX monitoring team recent research. And then we'll dive into a discussion today about value-based healthcare models with Pat Scow from the Illinois Critical Access Hospital Network, Tim Putnam from Margaret Mary Health and the National Rural Accountable Care Organization, and Charlie Alfaro from the Hidalgo Medical Services and Southwest Center for Health Innovation. So just a very short update here from TASC, but we are excited to announce to you all that Paul Luciano has joined the National Rural Health Resource Center. Paul is a program specialist. He'll be working on the TASC program, and you'll all have the opportunity to meet him at the reverse site visit next month. And speaking of the reverse site visit, the registration deadline is rapidly approaching. There are just 7 more business days to secure your hotel room for the 2015 FLEX program reverse site visit and the facilitation skill building workshop. And these are the in-person FLEX grantee meeting events for 2015. So this event is supported by the Federal Office of Rural Health Policy. It's going to take place June 22nd through the 24th in Bethesda, Maryland. And the theme for this year's event is Pathways to Value. There will also be an opportunity at the reverse site visit for regional project officer meetings with the Federal Office of Rural Health Policy, as well as an opportunity to meet one-on-one with your project officer. The hotel room reservations must be made by next Friday, May 22nd, or the room block will be released, and we can't guarantee the price or availability of rooms in that hotel. Registration for the facilitation skill building workshop, which is optional, and for the reverse site visit must be completed by June 1st. There's no registration fees associated with either event, and the intended audience for the FLEX program reverse site visit are state office directors, FLEX coordinators, and other state FLEX program personnel, up to 2 per state. The FLEX monitoring team, the TASC advisory committee, and staff in the Federal Office of Rural Health Policy will also be in attendance as speakers and technical experts. Both events are being held at the DoubleTree by Hilton in Bethesda, Maryland. But note that completing your online registration process does not reserve your hotel room. You need to do that separately. So just a reminder to please make your reverse site visit registration completed online, and then to secure your hotel room independently by next Friday. And that is all that I had for an update. So I'd like to now turn things over to Kevin Cheney and Aaron Fishbach from the Federal Office of Rural Health Policy.
Thanks, Tracy. Not to, again, belabor the point, but if you haven't signed up yet, make sure you do so for the reverse site visit. We're looking forward to seeing everybody come June, and this is going to be a very busy few months for the federal office. We've got a lot going on, both with the start of kind of the regional meetings that are getting ready to start and kick off actually next week, I believe, and just a lot of other activities and things going on. Your FLEX applications have been in. They're currently being reviewed not only internally by our staff and your project officers, but as well as by our review committee that's going to be meeting in a few weeks to score the applications, and then it immediately kind of starts into that next part of the grant process, in which you may be starting to be contacted by us. But I would also just encourage, again, to utilize the reverse site visit as an opportunity to speak and meet with your project officer. It's a good opportunity to talk about what's been going on, as well as what's coming ahead, and the new kind of maybe flex program that you've proposed and have, we'll be hoping and waiting to hear about both the score and kind of the next steps. So we're all very excited about that. Some of you who also work on the SHIP side of things for the SHIP grant, we've also have those in, and we'll be starting our reviews, and you'll probably be hearing from many of your project officers in a short time coming over the next couple of weeks, in addition to, again, with your flex applications. And then finally, what I've got here on my list is some people may have seen it, might not have questions coming in, but we did release from the federal office a grant notice out to develop basically a quality technical assistance group, in addition to kind of the activities that TASC is doing, but this would really focus more on the quality aspect, things like quality reporting, quality improvement. Obviously, big reason, and as you saw in the Flex request, is a heavy emphasis on quality. And so we're definitely looking forward as an office, hopefully, to see what comes in. Those will be reviewed, scored, and then hopefully sometime this fall we'll have a new cooperative agreement set up to assist us and provide more kind of in-depth technical assistant needs as it relates to quality reporting. In case you're curious, you're not necessarily eligible to apply, and neither are your critical access hospitals. We've actually had a couple of calls contact us. We're really looking more towards kind of a group that has a strong focus and kind of quality improvement, as well as providing that type of technical assistance. That being said, like I said, we've got a lot going on this summer. If you have any questions or concerns, always reach out to your project officer or myself. And with that, I'll hand it over to Aaron.
All right. Any questions for Kevin before I start? All right. Hearing none. Do I have control of the presentation, or can you advance the slide?
You should be able to advance your slides, Aaron.
There we go. All right. Just a couple of updates for this quarter. We're just before the release of a bunch of the proposed rules in the annual rulemaking process, so the next quarter will be full of items. So this one right now, the first one that went out is the inpatient prospective payment system, and thankfully for critical access hospitals and others, it was pretty quiet on our front. So there's a small increase that was proposed overall for PPS hospitals, that there's some changes to the quality reporting program in terms of measures. They made some updates to the hospital-acquired conditions reduction program, the readmissions reduction program, and to the value-based purchasing program. And they're asking for comments on some issues related to the bundled payments for care improvements initiative, and if you have some long-term care hospitals in your rural areas, there are just a few. Note that the SGR Reform Act of 2013 actually, as part of the pay for, cut payments to long-term care hospitals by starting to equalize some of the payments, so where they were getting paid more for the same or very similar services at regular PPS hospitals, they started to adjust those payments down. The comments are due on this rule by June 16th. That is based on when the rule went online for public inspection at the Federal Register. The original notice said June 29th, but they corrected that because that was when it went on display. The next slide, just reiterate, we notified you in the last call about these state operating manual updates, but we didn't have the actual manual completely revised. They had put out the survey and certification letters and had draft versions. Now they've finalized the updates. So the critical access hospital manual updates, which is Appendix W, is now out, and reiterate the list of things that we provided last time. These are basically all from the 2014 regulation changes that they're implementing, and any minor cleanups other than that. And then in the last one is the other state operations manual updates. There's the Appendix G for rural health clinics and FQHCs that also included some updates from 2014 regs and a little bit on hospital swing beds, but nothing major at this point. But there's a lot coming through the physician fee schedule and a little through outpatient PPS, and then they'll be implementing the new SGR law as we go. So I'll see if there's any questions on any of these items or anything else generally on policy and regulatory that we can try to answer.
Thanks, Aaron. Any questions for Aaron? Press *2 on your keypad to unmute your phone.
Let's play Stump Aaron. Nobody? All right.
Thank you for your time. We appreciate it.
Have a great day. Bye-bye.
Great. So now I'd like to welcome Mark Holmes to the call. Again, Mark is from the North Carolina Rural Health Research and Policy Analysis Center at the University of North Carolina at Chapel Hill, which is one of the 3 partners in the Flex monitoring team, and he's going to provide us with an update. Mark?
All right. Hopefully I did this, and I'll just start talking and someone will yell if they don't hear me.
You're good.
So, one of the main things that the Flex monitoring team does is publish reports on data that are collected. And we at UNC, for example, have done a lot with the financial indicators over the years. We're starting to move to more of a web-based delivery system. What I mean by that is that in the past, your reports for each of the hospitals and the state summaries have been available on the web, but we're moving the data itself into a online database so that, for example, you'll be able to create your own queries if you like and say, compare myself, for example, hospitals can compare themselves to other hospitals in their census division that have small revenue but have long-term care, and that ability to customize the peer groups has not been possible in the PDF-based format that we've been using in the past. Those are on track to start being delivered at the end of June, so in the next 6 weeks or so. We've got a very rough prototype at this point, but we're making a lot of progress on that. What that will require, at least in this year, is for still to log in for both using the Flex Coordinator passwords that you all have, and hospitals will log in as well. It will overlay relevant data from the hospital standpoint. They'll be able to see their financial data and then again customize them based on the peer groups for different indicators. From the Flex Coordinator standpoint, you all will be able to create multiple comparison groups and look at how your hospitals are doing as a group and see them individually, and allow a little bit finer drill down in a more interactive system that's been possible in the past. So we're on track to launch the finances there, as I said, in the next 6 weeks or so. We are also actively exploring the ability to move community data. By that, these are the data that Maine has been taking the lead on in the past in collecting and distributing. Many of those would be what I'd probably characterize as market-level data, community, county health rankings, these kinds of things that describe the context of the community, of the hospital. And we believe we're less confident about that, but we think we're going to be able to float those as well by June 30, if not later this summer, to have those, again, the same type of thing in the web-based system. We're also working on quality data. Now, you may know, you should know that Minnesota has taken the lead on publishing state-level summaries using primarily hospital compare data. We've been charged and been working on a system to deliver hospital-level quality reports. Many of those would echo what are currently available on hospital compare, but would provide additional context that hospital compare does not always provide easily in the current system. One of the struggles that we're facing are issues, as you might imagine, of small sample, and so limitations on what data can be reported for small denominators. And we're working through different models of providing something that we think is valuable, but yet underscores the imprecise nature when we use a smaller sample of, for example, 12 chart audits. You don't want to, you get 11 out of the 12, you don't want to get too excited, but you also don't want to, but you do recognize that that is moving, that is a data point to be collected. So we're developing a couple different approaches to that. If that's something that you have a strong opinion on or would love to be involved with, and how to deliver that information in a meaningful way that would give both the coordinators and the hospitals value, but yet recognize the limitations of it, we'd love to hear from you. I'll give some contact information at the end. Finally, I think the other relevant information at this point is at the reverse site visit. One of the things that we'll be doing in George Pink is, many of you are familiar with a financial distress measure that we developed a couple years ago to characterize the financial distress of critical access hospitals in the next 2 years. And it uses financial measures as well as some market level measures and isolation to put hospitals into buckets, if you will, of whether they're high risk or low risk to have some sort of financial distress in the next 2 years, to be precise. We've expanded that work to involve all rural hospitals. We've strengthened the model. It's performing better now, adding a couple additional variables, more context, and we spent more time drilling down on what these buckets mean. What does it mean to be high? What does it mean to be mid-high, for example? We're planning, I guess I should say, at the reverse site visit, every coordinator will get a list of the hospitals that we've identified as being high risk in your state, and really validating the method. How are we doing? Are we getting the right ones? Are we missing some? Using this as an opportunity to figure out do we need how to titrate our model more? What kinds of elements are we missing? What do we need to be building in? Are we missing certain hospitals or certain types of hospitals systematically? So be thinking about that. I know everyone here will be at that reverse site visit, so we will make you work a little bit at that session, but would love to hear your feedback and see the extent to which you walk in with your list in your head of hospitals that you're worried about their financial condition, and seeing whether we've identified the same list, and if not, working together to find out what we can do to improve that. And that pretty much summarizes the news from FMT.
Thanks, Mark. Does anybody have any questions for Mark? It's *2 to unmute your line. Okay, well, I know that we here are really excited about kind of the path that you all are taking and making some of the data more accessible on the website, and some of the messages you've also been sharing about starting to send out the financial data to the hospitals, and having that only communicated with them electronically as well too, and just some advancements that way. And then I'm really excited about kind of the recent developments we've had with what to do at the reverse site visit and how to share that new distress model that you guys are working on. I think it's an awesome opportunity for all the state flex programs to be able to provide their opinion, their input into the work that they'll be using too. So the thanks in advance to the Flex Monitoring team for being able to participate in that discussion on behalf of all of us.
Thank you.
Okay, well, I think what we'll do then is move into our topic of the day. So, as I mentioned earlier, and I think we're all aware of this, we're in this rapidly changing healthcare environment. And so having a discussion about value-based healthcare models is something that we've done in the past via other modes, and we felt that it was timely to bring it up again, and it's certainly something that we'll talk about at the reverse site visit and just can keep continuing to raise awareness on and develop messages to share with the state Flex programs that you all can share with your hospitals in your rural communities and other stakeholders in your state. So today we've invited 3 experts that are either participating in or researching value-based models to join us and lead us through a conversation about why rural health is moving to value-based models, obstacles that are in the way of adoption, strategies and tools that can be used in the transition, some of the positive outcomes as well as the risks of adoption of value-based models, and lessons learned to date with value-based models. But first, what I'd like to do is lay the groundwork kind of with some common definitions. So what we're going to talk about are what are accountable care organizations, coordinated care organizations, patient-centered medical homes, and population health. And they might not be definitions that we all 100% agree on to a T. There's different ways to talk about these things, but just a commonplace for today. So accountable care organizations are a mechanism to monetize value by increasing quality and reducing cost. They're groups of healthcare providers that take responsibility for the cost and the quality of care for a group of patients or individuals. When an ACO or accountable care organization succeeds both in delivering seamless and high-quality care and then spending healthcare dollars more wisely, it ends up sharing in savings that it achieves for the Medicare program. So they are Medicare, currently mostly Medicare-based programs, though we are seeing some start to occur through private payers. And I'd like to share 4 of the Medicare-based ACO models, just in a little bit of background about each of them, just so that if you're hearing these terms, you might know a little bit more about what they are. So the Medicare Shared Savings Program is kind of the foundational program. And it helps Medicare fee-for-service program providers and helps them to meet performance standards on quality of care and putting the patient first. Medicare continues to pay these individual providers and suppliers for specific items and services as it currently does under the Medicare fee-for-service payment systems. But then the Centers for Medicare and Medicaid Services, or CMS, develops a benchmark for each ACO against which its performance is measured to assure whether or not that quality of care is being achieved, and then to what degree there's a shared saving. So for this model, CMS has implemented a one-sided model where there's shared savings, but there's no risk for a loss that might occur. And then there's a two-sided model that shares in both the savings and the losses. And it allows the ACO to opt then for one or the other model, at least within their first agreement period. And under both models, if the ACO meets quality standards and achieves savings, and then also meets or exceeds the minimum savings rate, the ACO then shares in the savings based on a quality score for that ACO. And there's a similar mechanism then for losses too, if they're not achieving set standards. So in a nutshell then, that's the Medicare Shared Savings Program. Then the Medicare payment, the Advanced Payment ACO model is a supplementary incentive program for selected participants in that shared savings program. And through that Advanced Payment ACO model, the participants receive upfront and monthly payments that they can use then to make investments for things like care coordination infrastructure. It's targeted for rural providers and physician-based providers. And that Advanced Payment ACO model is really meant to help smaller ACOs that have less capital to participate in the shared savings program. And it's then testing whether an advance, providing an advance in the form of an upfront payment to then be repaid in the future really increases the participation in that shared savings program, and whether those advance payments allow ACOs to improve care for beneficiaries, generate Medicare savings more quickly, and then increase the amount of Medicare savings. The Pioneer ACO model was for is for early adopters for coordinated care, and it's really designed for healthcare organizations, providers that are already experiencing coordinated care for patients across care settings. It allows for these provider groups to move more rapidly from a shared savings payment model to a population-based payment model. And that's on track, but it's consistent with, separate from that Medicare Shared Savings Program. It's designed to work in coordination with private payers by aligning provider incentives and seeking, of course, then to improve quality and health outcomes across patients in that ACO. And then lastly, the next generation ACO model is an initiative for ACOs that are experienced also in coordinating care for populations of patients. And it allows these provider groups to assume higher levels of financial risk and reward than what are available under the Pioneer model or the Medicare Share Savings Program. And the goal of this model is to test whether strong financial incentives for ACOs coupled with tools and support really betters patient engagement and care management, and if it can improve health outcomes and lower expenditures in that Medicare fee-for-service payment world. So there's two different risk arrangements in this model as well. And right now we're in the first round of an application period that ends June 1st, and then there'll be a second round in June of 2016. So the ACOs have experienced rapid growth. In August of 2012, which was just under 3 years ago, there were 154 ACOs throughout the country, and in January of this year there were 747. They're led by both hospitals or physicians, and as I mentioned earlier, they're either have Medicare or private insurance models, and that number is really growing rapidly in rural areas too. And there was research just out in the last few days from RUPRI on the characteristics of rural ACOs in a survey of Medicare ACOs with rural presence. So please take an opportunity to look at that rural research that was sent out through the listserv, because it's valuable information and it's insightful to rural providers that are partnering in ACOs right now. Another value-based model to discuss is one that's occurring in Oregon, and it's coordinated care organization. This model pays for health care to get a better value and for health plan consumers to get a higher quality of care at a price that's affordable. In Oregon, they're experiencing improved, more integrated care with this model, and it's focusing on primary care and prevention. And the health plans and providers using this coordinated care model to better manage chronic conditions, keep people healthy and out of the emergency department. It's a network of all type of healthcare providers that have agreed to work together in their local communities to serve people who receive healthcare coverage under the Oregon Health Plan, which is their state Medicaid. And this coordinated care model has also been implemented with the Public Employees Benefit Board for state employees as well. The patient-centered medical home is also referred to as primary care medical home, and this has 5 functions in it that are comprehensive care, patient-centered care, coordinated care, accessible services, and quality and safety. So this is something that under state law is occurring in Minnesota, so we have a strong prevalence in here and actually have a national or a statewide conference, happening this week that's talking about these patient-centered medical homes and other models of advancement here in the state of Minnesota as well. And then lastly, just to lay the kind of a common definition for population health, and this is one that can be discussed in a couple different aspects. We at the center have talked about the definition at length and kind of are in alignment with that of the American Hospital Association. But population health is really what are the main outcomes for the future of healthcare in our country. So it is important to have a common understanding of where it is that we're visioning this care. And in population health, at the center we view it under 2 different buckets, I guess, if you will, for population health, or 2 different ways to slice it that are both extremely relevant and can both occur in a community or can be situationally dependent. So the first is that of targeted population health, where that targeted population is improving the health and reducing costs for specific groups of patients that are often grouped by insurance type, or they're focused on a chronic disease or maybe a demographic type. And the second is that of total community health, where it's looking at the population health and health outcomes of an entire group of individuals. that are often geographically defined, so maybe the current population that's seeking care at a critical access hospital or their potential market share, and looking at the distribution and disparities of outcomes within that group. So I like to think of it as kind of the small N under targeted population and the big N under the total community health for those of you that might have a statistical background. So just wanted to share those common definitions to kind of establish a baseline for where it is that we're talking today. And now I'd like to introduce to you the panel that we have asked to help join us through this discussion on value-based application and value-based models in rural America. So Pat Scow is the Executive Director of the Illinois Critical Access Hospital Network, or ICANN, and that's the first statewide critical access hospital network in the country, and it was established in 2003. ICANN is a nonprofit organization. They're comprised of 51 critical access hospitals, and they provide a number of hospital service programs for its members, as well as administering the Medicare Rural Hospital Flex Program, the Small Hospital Improvement Grant Program, or SHIP, and several other grant programs on behalf of the Illinois Department of Public Health. Pat's also the chair of the TASC Advisory Committee. Joining Pat is Tim Putnam, and Dr. Putnam is the president and CEO of Margaret Mary Health in Batesville, Indiana, which is a critical access hospital, and he has over 30 years of healthcare experience. Tim serves on the board of directors for the Indiana Hospital Association and currently is chair of the National Rural Health Association's Policy Congress, the University of Kentucky MHA Advisory Board, and the National Rural Accountable Care Consortium. He completed the National Rural Health Association's Rural Fellowship in 2011 and frequently lectures on community health care leadership at Xavier, Indiana University of Kentucky Healthcare Administration programs. Dr. Putnam also serves on the Federal Office of Rural Health Policy's National Issues Group and is currently pursuing certification as an emergency medical technician, or EMT. And joining Tim and Pat is Charlie Alfaro. Mr. Alfaro is the Executive Director of the Hidalgo Medical Services Southwest Center for Health Innovation and the founder of HMS, a community health center providing primary medical, dental, mental health, family support, community development, and health policy services in southwestern New Mexico. He has over 36 years of experience in rural health and in rural health policy systems and program development. He's been the Director of Rural Health Outreach for the University of New Mexico Health Sciences Center and the Director of Community Health Services Division at the New Mexico Department of Health. He has experience as well on the National Center for Frontier Communities in New Mexico Primary Care Training Consortium and serves as a consultant for the National REACH Coalition. So with that, I'd like to turn things over first to Pat Scow. If she could kind of explain to us through her lens what her experiences have been to date with value-based models and kind of why it is that we asked Pat to join us today on the call. And Pat, it's *2 to unmute your line.
Can you hear me now?
Yes.
Oh, wonderful. Thank you, Tracy, and it's a pleasure to be with you today. I know all of you are fairly familiar with the Critical Access Hospital Network, but the reason I had this slide put up is just to talk about the area where we're talking about members and how we got into the value-based purchasing discussion. About 1.5 years ago, our hospitals were looking at what are they going to do, and as we look for value-based purchasing and patient-centered medical home, and what is all this ACO stuff anyway. So we did a lot of discussion, and we had a number of critical access hospitals that are still independent. Many of them were wondering, do I merge with a system? Do I stay independently? You know, what all does that lead to me? You know, and there's some states that, you know, most all their hospitals are part of a system. While Illinois, they're still pretty independent. And so that led us to looking at how we might be able to work those that are independent as a group, and also continue to provide the same kind of hospital transformation information for the rest of the critical access hospitals in Illinois, just because we're focusing now on some of these efforts with the independents does not mean that we don't have the systems hospitals participating periodically and so forth. So, and ICANN, and that's really part of the FLEX program, has always been an incubator for new ideas and services, and I think that's the really intimate value of the Flex program, and it provides states some flexibility and opportunity to try new things. So if you want to do the next slide, Tracy, over the last year, we embarked on applying as a group of 21 critical access hospitals to become a Medicare Shared Savings Program, which Tracy spoke about just a few minutes ago. And we titled it the Illinois Rural Community Care Organization. And really what it is, it's an activity and a process and an entity that will help get us to the point where we need to be, where we actually have value-based care. When our hospitals decided to move down this path, they felt that they needed an organized structure. They needed some discipline to do that, and so that's why we moved to ARICO. It is actually, the MSSP is underneath the ICANN as an organization. It's a separate entity, and it's functioning like, it's an LLC. But what I really want to call your attention to is the vision which they created, that they really felt it was just a collaborative, not only of critical access hospitals, which is driving it right now, but the physicians that they're hand-in-hand in partnership, social services, and we hope to add other rural hospitals. And what we're trying to do is we believe if you move towards value-based care, you have to create the change locally, and we need to use our own talent, so we build our clinically integrated systems. You have to build from the grassroots or from the inner side out, and putting the patient in the center of it. So that was really important to our efforts. And when you look at value-based purchasing, it's really about the patient. The patient is in the center of it. But it's changing how we manage the patient around them and how we think about it. And all these things that we've looked at and talked about over the years, sometimes it's just coming together when we start thinking about the patient as the real crux of it. Next slide. With our ACO, and this is probably a slide you've seen that others have had before, but we felt it provides us the overall framework as we start looking at the ACO and we start looking at value-based purchasing and how we move to that type of format and delivery. And as I remember, even though we have 21 of our 50-some hospitals in this ACO, doesn't mean that any of our programs, they're always open to our other critical access hospitals. We're doing a lot of work on transitional transformation, and they're all part of it. But our ACO, you can look at it from the buckets that we feel we need to complete and capture to make all this come together. We have to build evidence-based care, and you may hear me talk about it a little bit later. My chief medical officer says, gosh, I hate talking about best practices. He said, I really like dealing with proven standards of care. And that's really what the Geisinger model, when they deal with value, is looking at proven standards that work in your rural communities. And you start to compare and look at value. You want your patients to always, if they're a diabetic and they're part of your value-based care system, that they're going to have this type of treatment and care and management. Your providers have to be part of it. Care management obviously is the glue. Financial performance, we're looking for, better price, better efficiency, all the triple aim. Predictive modeling, and that's what we've really not done a lot and that we're learning about, our high risk, our targeting populations, as Tracy mentioned early. And the IT is the other part of that, the other part of the glue there that we hope to use to really deal with point of service and be able to pull all this information together. I was talking to my chief medical officer the other day, and I said, well, how do you coordinate care? He's an independent physician I've worked with for 30 years in Princeton, and he's a solo practitioner. He says, well, every day he gets a stack of facts, and he follows up with the nursing home. He follows up with the hospital, about a lab test. He might make a call at a patient. He might follow up on a patient that fell out of a bed at another nursing home. But anyway, it was all facts orientated. There was no transition to the care plan or incorporated into the whole disease process management. And so we move to value. We'll start bringing all that information together so we really have a complete picture. I think I've covered my slides to the next one. Tracy, I'll turn it back to you.
Thanks, Pat. So Tim, could you join us now and share with us a little bit about your perspective and your experience with value-based models? And it is *2 to unmute your line, Tim.
Yep, I gotcha. Can you hear me well?
Yes. Thank you.
Fantastic. Well, I guess our transition started when our board met a couple of years ago, or actually 2.5 years ago, and it really came from a focus of why we are here as an organization. So ours is a critical access hospital in the Midwest in Indiana. It was formed by the community, so we've always had a community focus. What do we do? It's not about increasing our bottom line. It's how do we serve the community better. And I think it's really been interesting. We are part of an ACO, so we banded with other hospitals, much like Pat did on a state basis, but we grouped with other hospitals across the country to form an ACO, and it's really been an interesting transition. I don't have the ability to advance my slides, so you might want to.
Yeah, we have some of your slides. You have some of your slides later on, Tim. We're just, I think, right now looking for your perspective about your role in the National Rural ACO and involvement with that.
Yeah, we got together with these hospitals that had a like mind, that we wanted to learn how to become part of providing better value, better care for our patients in a new model. We were kind of frustrated that the rural hospitals were being left out of all of it, and we really wanted to be part, so we had to work very hard to find a way. 2.5 years ago was a rough path to get into any kind of value-based models. Everybody was looking at us, you don't have 5,000 Medicare lives, which is the minimum for an ACO, so therefore you can't be one. So that's where we joined with the other hospitals, looking at how to deliver this kind of care. And really our goal was to deliver better care, but really learn how to survive in a value-based model.
Excellent. Thanks, Tim. You know, even just hearing from you, Pat, and Tim so far, it's exciting to hear about the innovation that you've taken on to even, and the risk you've taken on to develop your model too. So Charlie, I'd like to invite you to join us now too, to share your experience then with value-based models and to describe this slide to us as well about your perspective on the model. And it is *2 to unmute your line, Charlie.
Can you hear me now?
Yes, thank you.
Okay, thank you. Yes, the Southwest Center for Health Innovation is located in Silver City, New Mexico. We are a division currently of Hidalgo Medical Services, which is a community health center. We come from a very sort of frontier and primary care focused perspective. We believe that the primary care system is sort of the answer to the triple aim discussion, and are trying to figure out ways of aligning payment systems to support rural and frontier communities in a better way than fee-for-service and volume-based payment systems. We are looking at different models for population health, and you see our patient support system model on the screen in front of you. And part of what we're interested in also is looking at uncoupling payments from historical connections. By that I mean, for instance, hospitals are recipients of indirect medical education funds for training physicians, and they're the only ones that can receive those graduate medical education funds. And what happens if we uncouple that payment system from the hospital? Can we change the ratio of primary care providers trained versus the current system, which is dominant, as you know, in subspecialty training? And as a result, we've worked with our Medicaid program in New Mexico, and Medicaid is now financing primary care-based residency training directly to FQHCs. So now we have an ability to generate training in a workforce in primary care that's uncoupled from urban-based subspecialty hospitals. We're looking at that for patient support services. As you know, about 70% of all patient visits are social issues related as opposed to purely clinical. And however, the payment system currently couples all clinical interventions with licensed health professionals except by contract. And sometimes we wind up getting into sort of conflicting incentives for providing care. On one hand, we say we'll pay you fee for service for delivering care, and on another hand, we'll say we'll give you a bonus if you don't spend too much money. And so what we're trying to do is figure out how to change the incentives and put them where they need to be in order to reduce costs and improve health. And that's what we're working on. Did you want me to go over the slides specifically now, or were we coming?
I think if you could walk us through reading this slide, that would be really fantastic.
So in this case, we're looking at our patient support systems model. And the bell-shaped curve that you see is population, and some people are in excellent health. They're at the left end of the bell-shaped curve, and some people are in very poor health. Of the people that are in very poor health, 5% of the patients generate about 50% of health care costs, and as you know, 20% generate about 80% of health care costs. And yet, in a primary care setting, in an FQHC or in a rural health clinic under Medicare and Medicaid, we get a cost-based reimbursement or a PPS rate, regardless of what we do with the patient. So the incentive in this case is for primary care providers to see as many patients as they possibly can, not to improve their health, because we get a fixed payment per visit. So what do we need to do to sort of mitigate those incentives of volume to actually focus on health? And what we've done is create a three-level system of looking at how to support patients better. And I like to think of this as a PCMH plus quite a few. And so we're working on a model right now with 2 of our 4 Medicaid managed care organizations where they're referring to us their most expensive patients, Medicaid patients, regardless of condition. So we're not focusing on just diabetes or hypertension, but any condition which a patient has high costs, and we're managing them with community health workers. And we receive a contractual PM per member per month payment for the number of care coordination patients that we have. So there's not specific visit-related payment base, but a care plan and an accomplishment of work. And these patients referred to us at the high end, at the level 3, are at 100% case review on a monthly basis. And in our model for developing this a couple years ago, over an 18-month period, we found that using community health workers, working with the most expensive patients, that we were able to save 4 Medicaid dollars for every dollar spent on the program. And again, these are the most expensive patients. So with those savings, we thought, well, what can we do to start working on upstream issues? How can we get paid for non-clinical patient support services without a face-to-face visit with a medical provider? So as of July 1, we're rolling out a level 1 and 2 plan. We'll work with chronic disease management, clinical preventive services improvements, health education, and look at community health priorities and determine intervention strategies. And those are all being paid by a separate per member per month rate for 100% of the Medicaid population. So we have one rate per member per month for 100% of the Medicaid population, and a different rate for the high cost patients. None of these intervention strategies require a medical office visit for them to be paid. However, obviously the connection with the primary care system is critical in terms of the clinical aspects of patient management, and also the determination of who is referred to us comes from the medical billing process. So we can identify from the MCO databases those people who are first-time patients that require patient support services. So again, these are per member per month contracts that are supplemental to the payment contracts we have for both private insurance and MCO providers. And what it does also, in our primary purpose in doing this, is to create an equity position within the healthcare system from a revenue perspective for patient support services. What I mean by that is that the healthcare system is typically dominated by those programs that generate the most revenues. So there's a lot of incentives to generate revenue, and the best way to do that is to provide high cost, high yield sort of services in terms of revenue, but there tend to be also high cost, low on the health outcome side of things. So by creating a revenue source for patient support, we're sort of equalizing the playing field in the health care system decision-making process. And our organizational chart reflects that. The community health worker director or family support director, in our case, has an equal position on the org chart to the chief medical officer, chief dental officer, chief behavioral health officer. And this way we're looking at health from a broader horizontal perspective.
Great, thanks Charlie for explaining that. This is a great visual, I think, for understanding the distribution of the population and those costs, where the level of care needs to be and the right workers to cover that. And I love how you explained your downstream approach to kind of take care of those patients that were the neediest with the highest cost, realize some savings. They would be able to take those savings and apply it upstream into prevention and wellness strategies that, like you were saying too, are often under-prioritized or not at the same level, and I like how you balance that out within your organizational structure. So I have a few questions then that we'd like to share with the panelists and get your perspective. And Tim, I'd like to start with you. So with regards to the value-based model of care, what are the main reasons rural healthcare providers are moving in this direction? And I have a slide to share that you provided to us that might help you talk through this a little bit.
You know, we got into it a couple of years ago, but even before the official language that you're starting to see really become prevalent in the last few months about the direction that CMS feels it's happening, there's not a day that goes by, there's not a new article going that we're talking about moving to a value-based payment system. And now people are actually believing it. But even as long as 2 and 3 years ago, when we would talk to people at CMS, legislators on both sides of the aisle, both conservative and liberal, were saying moving to something, they'd use a little bit different language, but moving to something that pays for value instead of paying for doing stuff was coming down the road. And one thing I learned a long time ago is when the Democrats and Republicans are both saying the same thing, you can agree that, or you can bet they're going to agree on language to make it happen at some point in time. And that's what we really saw. The other thing is, and here's where my passion comes in, that I think small communities can do this better than it can happen in a rural area, is that it's our reason for being. It's our existence to improve the health of the population, to make people in our, to serve the health needs of people in our community is pretty much the mission statement of most rural clinics and rural hospitals. It's why we exist, not to improve the bottom line or to provide good care to a portion of the population or something like that. It's to make these overall improvements in the community. So when we talk about moving to a value, making people healthier, reducing the cost of healthcare, that is in our wheelhouse. That's what we're here for. And my frustration about it earlier, when the ACOs were first formed and there was a 5,000 individual limit on it, it was really kind of frustrating that the community health organizations, the community hospitals and rural places were left out when we were ideal for bringing this kind of solution to bear. So when you talk about why we should do it, you don't have to look much farther than your mission statement.
Yeah, that's a great point, Tim. Pat or Charlie, do you have anything to add about reasons for rural health participating in these value-based models?
Yeah.
Oh, go ahead, Charlie.
Thank you. You know, we've been sort of trying to modify the fee-for-service model annually since there was a fee-for-service model to try to adjust for the lack of volume in rural settings and frontier settings. And we go to Congress every year and we tweak this and we tweak this part of the payment system, and it never has worked well because, again, I think we have to find ways to put the incentives in what we really want to do. There should be a direct correlation between the health goals of the country and how we get paid for health care, as opposed to rural providers being forced to figure out how to stop the financial bleed of services from rural to urban areas by replicating urban-based clinical services in a rural area that ultimately does not have the volume to support them. And it's a critical part of our thinking. How do we design a system so that we can invest more smartly in rural healthcare and make sure that there's access going forward?
I just want to add 2 comments. One is that the hospitals felt that the critical access wanted to be part of the solution. They felt that that was the reason that they would get going now, and that they could be part of the solution. The other thing is concern about market share, which Charlie alluded to, is that with all the changing environment, they felt that they really needed to understand their community. They need to regrow their primary care market share, and to do that, we had to focus on value, which we do best with primary care.
Absolutely. That's exactly right. Thank you, Pat.
And the other thing, just quickly to add, is, rather than trying to stop the exodus of dollars by creating more expensive services in the community, we can do that the same way if we can figure out how to get paid for management better. Having a small add-on to a medical office visit for PCMH is not enough of an incentive to manage patients more effectively, especially the high-cost, complex patients. So that piece, the patient management piece, I think is a really critical part of stopping the bleed and also improving the quality of life for the people of rural communities.
Mm-hmm. Right, and that's a good segue, because our next question is about some obstacles that are standing in the way of adoption. I think that patient management piece and adjusting our organizations, whether they can be part of an ACO or a patient-centered medical home or whatever it is, but adjusting them to thinking about value, even if they're not part of one of those systems or models yet, is really critical. But there's obstacles in the way, whether it's the 5,000 lives or other barriers. So, Pat, could you start us out with talking about some of the biggest obstacles that you see standing in the way?
Sure. Just a couple of things. One is that you have to look at rebuilding your service. And what are we going to do internally to manage this change? We have a lot of, if you look at the critical access hospitals, the design and care delivery is still inpatient. Even though we've had this outpatient focus, we still have case management in the hospital and so forth. And so what we feel that our obstacle is we have to rethink and retrain everybody, get those staff that are working in the clinic areas and the practice areas to start looking at patient-centered medical home or something similar as a foundation, and learn to understand the data to make changes based on that, the data, and then look at redesigning, like I said, internally your care processes and things like that. And it's going to take us time. It's not going to happen overnight. I think the adoption of patient-centered medical home is up to 18 months. And so it's that transition is a kind of a rethinking, a retooling that'll be very important to us, and that, we really have to show what our quality is. And so it's building what we're going to be for the future. And so that is a challenge. The other challenge, you want to go to the next slide, is being able to deal with all our disparate electronic medical records. Of our just looking at our ACO, that we have the 21 hospitals, and I have 181 different NPIs, physicians and clinics and things like that. We have 15 different outpatient EMR records and things like that. And so how are we going to pull all the data together to understand it? And we have a tremendous knowledge base that we have to build, and data analytics and care processes and so forth. And most of the time, small community hospitals, we're going to have to build it as you go, cash. I don't have any grant dollars or anything like that. The hospitals have put their money out there to make this change themselves. And so we can do that if we take our internal work and we start redesigning it. We don't go out and just add new people, because we're going to have to live with these new processes in time to come. So, you know, and the challenges is last of geography and variability and in bringing all that together, because we've been independent, and so how are we going to have the benefit from the shared efficiencies and in care management, sharing of those services if we don't know each other and learn to understand the way we all practice it. So, you know, looking at building the services internally and regrouping, IT, understanding data, and then learning to work together in variability of practice, not just sharing information, but, you know, sharing how we're going to manage the patient and share that information back and forth, and money.
Great. Charlie or Tim, anything else to add as far as large obstacles in the way of adoption?
Well, this is Tim. One of the things I'll say is that the funding out there, much as we talk about it, and Pat alluded to it, to do some of this is not there. Medicare Shared Savings ACOs are a good plan, but it's definitely not enough and really delayed in payment to make it happen. So the funding models are really not very strong right now. It's why we see some obstacles in there. You know, I'm having a discussion with my chief medical officer, and I said, you know, if we just were given the amount of money we were given last year from Medicare and told to deliver care better, we'd really make some changes and we'd be able to do some stuff. But that's not the way the model works, and it's not what we're allowed to do. And the other thing is the overall veil of Obamacare and the perception in an area like ours, which is largely conservative, that it's a bad thing. So crawling out from under that, with some of the discussions that I've got to have with people in the community, you know, when you say we're changing delivery of healthcare, that's one of the first things that pops up is, oh, this is that Obamacare. I'm against that. We want to repeal that. I heard that's going to be repealed. So a lot of the discussions with the community members that I've got to convince start like that.
I think.
Yeah, understandable. Charlie, do you have anything to add?
Yes, thank you. I think there's this concept that we're using in urban and rural areas sort of equally, and that's this concept of risk. I don't think the healthcare system has gotten to the point it's gotten in terms of inefficiency and cost by creating risk. What we've done is eliminate most risk for investments in high-end healthcare. We've created an incentives for investments in the things that make our healthcare system less efficient. And I think we need to learn from that and apply those incentive models to what we would like to see, which is value-based services, rather than creating risk for rural. Rural is already risky. You know, any investment you make in rural healthcare bears a different risk because of finite population, because of the inability to grow to certain volumes that would assure a profit. You know, we should minimize risk in rural healthcare. So withholding money or creating models that put the burden on fragile systems, I don't think is a good idea. We need to figure out ways to incentivize, pay adequately for the outcomes we want, and remove risk in order to create a better system.
Excellent. And that's why it's important to have folks like you guys representing us in our state offices of rural health and our flex programs on the national committees and things like that, that you are, you know, bringing up these issues and educating those that are making the decisions daily on where this healthcare train is moving down the track. So Charlie, if you can start us off then with talking about the next question. You know, we've talked about the reasons that healthcare providers in rural areas should be moving in the direction of value-based models, and we've talked about these obstacles and the risks. What are some of the strategies and tools that are being used in this transition?
Well, that's a good question. I think oftentimes, especially rural communities that are not organized in terms of the healthcare system on a broader level or within their states, often are passive recipients of policy. And so we sit in our hospitals or clinics and wait for somebody, in our case Santa Fe or Washington, to make a decision on how the payment system should look and what our options are. And we try to adjust or react to whatever those things are that we think, might be best for our organizations and communities. Our approach has been to take the perspective, if it's good policy, let's all do it. If it's not good policy, let's not try it. So, if we have a successful model, like in the patient support system one I went over with you, then let's try to figure out how to get paid for it, how to influence policymakers in Medicaid and in the legislature, if having rural-based physician training is desirable for immediate and long-term resolution of HPSA problems, then let's go to our legislature and our governor and say, hey, let's try this and be more proactive. And I think that's what we've done. It helps to have been around for some people it helps to have been around for, a long time and develop those kinds of relationships. But I think rural communities need to feel empowered that they can influence the decisions that impact their future.
Excellent, great. And I think that's a great segue about the relationships. Tim had some information he wanted to share with us about strategies and tools to be used in this transition, and his information to share is about communication and resources. So Tim, if you can talk us through the content on the slide here about communicating during the transition.
And that's going to be the theme of a lot of the slides I put together. It's coordination and communication. I have found this to be one thing that it gains a lot of traction. People are really interested in it. You have to communicate it a little bit differently. Hospital trustees, they want to see, they want to make sure the hospital fulfills its mission, so they're really interested in that piece of it. What's funny about this is I really always thought we were about health and wellness, but when I go out and talk to people in the community, community leaders, they think we're about treating illness, and that's it. And it was, oh, so you're into wellness now? And I said, I really thought since our inception in 1932 we were, but that's not how we're perceived in the community. We're just perceived about treating acute illness, disease, and trauma. So it's opened a lot of conversations that we wouldn't have before. And the medical staff is, again, a little resistant to any change, and the hospital staff is too. But they, when I talked to them, I said, well, what are the real things you need to treat your patient? Well, my patients can't even get to their appointments on time. So all of a sudden, transportation becomes an issue. And we have a good discussion about transportation. Well, I never get information back from our specialty physicians, and that leads to Pat, what she was saying about being on different EMRs. So how do we get through that issue? The community at large, some really interesting discussions, because some places we serve are very small towns that are isolated. So a town of 300-400 people in them have no social resources except maybe one or two churches. And how do you get them engaged? And you have these different conversations about delivering health care that you never did before when you're just fee-for-service, and really looking at just what Charlie alludes to as being paid for doing stuff. So now if you get paid to keep people healthier, that opens to more partners than you've had before. Really interesting partnerships that can exist with churches and social groups and different organizations than you really thought. I mean, we're looking at chiropractic differently. We're looking at our role for behavioral health differently. And so it spurs a lot of conversations. I talk about this changing every conversation I have with people.
Absolutely, and yeah, and reframing that conversation too to kind of tug at their motivations or their heartstrings a little bit too. I think we've been doing a lot of talk in our organization about different partnerships and rethinking what partnerships look like in the future. And we've come to agreement, and I don't think anybody on the phone would disagree, that no entity in the future can go it alone and expect to be doing the same services and working with the same partners that they were in the past. It just is not viable at all. Tim, can you talk us through this slide as well too about some of the resources that you felt were important for our transition?
Yeah, the very first thing is the data you get from the Medicare Shared Savings ACO. I really, when we started with this was sort of an asterisk or an afterthought from my standpoint because it was just payment data. So I thought, what value do I get out of payment data? But when you look at it, you get every payment Medicare made on individual patients or for patients as a group. And I can see that, and it's a conversation starter with a lot of these things. I know which one of our physicians, if you go to one of our physicians, you get a 74% chance of having an ER visit that year. If you go to another one of our physicians, you have a 36% chance. So what's the difference? What is one physician doing? Are they serving a different population? And I'm not saying one's good or one's bad, but it opens the discussion. And it allows me to compare one physician to another. I know which of our patients, because of the DME charges, are filling their glucose test strips and which ones are not. You know, we get some of the basic information. We always talk about immunization data and who's getting their flu shot, who's getting a pneumonia shot, who's had screenings for this. But we're getting so much information that our care coordinators, and it's sort of on Charlie's model of who's doing what with the level of intensity of patient, we can really use that data to find out who's on track and who's doing the things to stay healthy and what those barriers are. So I really dismissed the Medicare data when we signed up the program, but I'm really finding out that it's proving valuable at this point and helping us guide the conversation. The other thing is our experience with the National Rural ACO and some of the other organizations. Suburban Health is a group of hospitals in the area that are also going through the value transition, and other hospitals in the area. A lot of times we compete with each other, or at least think we do, or some level of one-upsmanship from one hospital to another. This has been something we've all sort of gathered around and shared best practices. It's not something anyone's keeping to themselves to be a strategic advantage over another healthcare system. If somebody finds something that works with care coordination or focusing on disease management or how do you reduce ER admissions, we're all sharing it much more so than in other projects that I've seen. So I think the ability to have groups like this share best practices, get chief medical officers of ACOs and other coordinations to work together is really valuable. And I think it's happening on a level with this that I've not seen with other projects that I've worked in the past.
Great, thanks, Tim. Pat, do you have anything that you'd either like to add to as far as strategies or tools, or emphasize that Charlie and Tim mentioned?
Sure. I don't know if you want me to do my slides. Are they for the next slide, or anyway?
Oh, yeah, you do. Yep, absolutely.
Yeah, I'll just do briefly a couple of comments. One thing, and I want to put it from the Flex Coordinator, what I think you can do is help your hospitals, because primary care is key to have those critical conversations. I've been at several governing board summits with medical staff and physicians when we're talking about value-based care and making this transition. Several physicians said to me, you know, this is the first time I've been asked about bringing my care plan and my ideas with the hospital and melding it together instead of the hospital just asking what piece of equipment I need. So it's really helping us have critical conversations, and that's part of the strategies that you have to have as we start to make the change within towards value-based purchasing. Next slide is you also have to think about how you're going to be special and how you're going to begin to make this difference, because it's a culture change that you're creating and how it becomes a positive experience. And so you want to have better outcomes and getting that message across. And we've been trying to use the old low-tech, high-touch and really try to meld and build something very special that why people want to be part of this change and why value will be so much different and be part of the believing of this process. The next slide is really, as Flex coordinators, is begin to have an understanding about the science of population health and the change, is that you have to look at your different segments of population, and what we want to do is to get to value is begin to reduce the variation between the care for each one of them and be a little, not necessarily standard, but, you know, find out what works works the best and be able to use it, or you can adjust and provide some variability to be successful. But begin to build some understanding, and I think you can provide some programs and education to help guide your hospitals, because population health is just a whole encyclopedia, but we have to begin to look at it in segments, and it's the decreasing in variation in care and targeting that'll help us to be more successful. So those are some of the tools that I think as flex coordinators you can think about and bringing it to the table and helping your hospitals.
Great. I think that definitely helps us change the lens and focus a little bit differently in the flex program or in our hospitals as we're thinking about the healthcare environment as we transition through it and really what it will optimally look like in the future. So then we've alluded to some of the positive outcomes, and we've talked a little bit about some of the risks. So I'd like to just kind of revisit that a little bit. And Tim, maybe you can start us off with talking about some of what the potential positive outcomes are of adoption and some of those potential risks as well, and some slides to share with that.
Well, categorizing patients, I think, is important, but Charlie hit on that, and your discussion about population health, of how to segment and provide different levels of care for patients. I can't add anything to that, but I just will tell you that that's important. The other thing that's of value are the different conversations that you have with different groups. Parish nursing comes and goes, and we can all think about some places it's either successful or was successful in the past, but it was sort of dependent upon one person. The hospital may have had a training program, but now when we think about population health and how to stay on top of things, now the question comes to our group: should we support it much more actively? If we can get the churches engaged in healthy behavior, which is our big resource in this region, how important is that? How should I put resources toward that? And before, you might get a little bit of funding for it, but now it might be worthwhile to have a strong program to make sure that works, to support volunteers at different churches. How important is transportation? That's one of the things that has a positive outcome. We're looking at people that have transportation, but they can't keep a 2 o'clock appointment because their transportation's not reliable. So how do we either get them transportation or be flexible on keeping a physician's appointment or appointment with their care coordinator? And the other thing is if we really want to make a difference in population health, one of the things that comes for our Medicare population is we all know the situation when someone is in their 80s and has the fall that fractures a hip. The hip can be repaired. There's a lot that's spent on that, but then that recovery is so long, a lot of times the patient develops some other issue, or just being sedentary for the time they're in the healing process is very detrimental to older patients, and they develop other issues and really never fully recover from it. So how much effort are hospitals and clinics today putting on loose rugs and poor lighting in people's homes, and how much should we be? So those are some of the things I think will be the outcomes. We'll start looking at this as our responsibility much more than we have in the past.
See, that loose rugs and poor lighting reminds me, last week I was at the National Rural EMS Conference, and they were talking about the use of community paramedicines, and those folks going in and doing those home visits and kind of assessing what the sidewalk might look like leading up to the home that the patient's at, and things like that, loose rugs and poor lighting that might be leading to causes an injury or not being able to, access their medication because their loved one is putting it in a place that they can't reach it and things like that. Sorry, go ahead, Tim.
I think one of those things is when you talk to physicians about what they need to get better care for their patients, right now, no physician hardly anywhere in the country can write a prescription for a carpenter to go into someone's home and put handrails up and make sure that stairs are secure and things of that nature. But should they, is sort of the question that we're having today. And that's the kind of thing that's really exciting about this, is it's changing the conversations we're having with just about everybody.
Absolutely.
I think that's excellent.
So talk to us, Tim, then about this, about surviving the transition.
Oh, all right. Not a lot of our rural hospitals are in such strong financial strength that they can make a transition like this. It's really difficult to do it right because we're still paid fee for service. We're talking about doing things that eliminate visits to the emergency department. I really worry that if we do wellness well, given this current model, and get really excited about it, it's going to reduce our revenue before there's a model in place to replace it. And we're doing these for the right reasons, but we're still putting ourselves at financial risk. One of the things that we found, one of the first pieces of data we got from the ACO, is that the average Medicare beneficiary costs over $10,000 a year, and the ones in our market are at $7,800 per year. So we're already substantially below the national average. Well, Medicare shared savings is based on reducing that. If I'm at $7,800, there's a pretty decent reduction that's going to take place. I'm going to have to be at $6,500 in order to get, just a few $100 in savings per beneficiary, and that's really tough to get down there. I don't know how much there is in savings, and then that's a 18-month delay before you get it. So you're asked to put a lot of effort and a lot of cost into, and building an ACO is not cheap to do it right. You've got to put a lot of resources for the staff. You've got to do things of that nature, and there's a financial risk. I think we've done a good job this last year, but we were also hit by a flu season where the flu vaccine didn't match very well what came in. So regardless, our costs will probably go up this year, and I think we put a lot of effort and a lot of resources to make things better for our patients. So even when you take that, the outlier patient that was a heart-lung transplant and things of that nature, there's risks that exist quite a bit from a financial standpoint in moving to this. I know CMS is aware of this, but you have to realize that when you're working with these hospitals, they're trying to reduce their revenue because it's the right thing to do for the patient, but they're putting their organization at a substantial risk.
Thank you. We have just a few minutes left, so Pat or Charlie, do you have any highlights of positive outcomes or risks that you want to be sure to add into the conversation? If not, we can move on then to our last question.
Yeah, go ahead.
And Charlie, I think I'll start with you. Can you share some of the key lessons learned that you've learned through your work with these value-based models?
Yeah, on the positive side, I would agree with the comment made earlier that rural areas are better testing grounds and more flexible in their ability to make changes. Just because of sort of and I live in a very, very rural place, frontier, so there's no competition or very little competition, and everybody knows each other, and so you can work together most of the time to design and think and do those kinds of things. And that works very well. And I've also learned that rural places can actually be the proving ground for urban models and not necessarily have to be always top down. All the good ideas don't always have to come from urban, state government, universities. It can come from the community, and the community can influence change. And I think that's a key lesson. And I also think this concept of uncoupling payments from our traditional way of paying for things is critical if we want to make meaningful change. We can't just keep doing the same things and expect outcomes to be different. You know what that definition is. So I think those are sort of the key pieces.
Thanks, Charlie. And Tim, you had some lessons learned that you've highlighted a lot through the things you've shared with us this afternoon. Can you add to this a little bit?
Yeah, I think one of the things is that CMS does change the rules pretty frequently, and the insurers expect different things, and that's been frustrating for our group as time's gone on. The other thing that I'll say as a lesson learned is this is not air warfare. This is not carpet bombing someplace. This is hand-to-hand combat. It's one patient at a time trying to figure it out and then building a good model to duplicate.
Great, thank you. And Pat, I know you had some lessons learned that you wanted to share as well.
Well, thanks. I really believe that care is local and you have to focus from there. The redesign has to occur that way. And the flex coordinators, if you could help your hospitals, whether they participate in ACO, but they start looking around at their medical neighborhood, how are we going to build out our process and start thinking, don't, look at how you can do it internally and learn from that. And it takes time, and it's really more of a marathon than a fast sprint. I like things to happen right now, and hearing from what Charlie's done, and I know Tim's experience this past year, it does take time to change, and we have to work in it together and be ready. We have to be in it for the long haul, and it's really important because our rural communities are really counting on our survival and our good instincts and our leadership to bring about this change. And we're talking about change. And like I said, I'm going to end with it because I really think with the Flex program, it's a perfect opportunity for us to reach out and push the system and make the change and give the resources to our hospitals. So, I conclude that change is a journey and that it's better to be part of that than not at all. So this is really an exciting time, and I think you look at the glass half full, and this is the time to think about how we really want to communicate. We want to make a difference using different types of, letting people work to the full capacity of their license or their training and rethink it. And it's a culture change for our physicians and thinking, as several alluded to, that it's not a treatment model, but it's a health model. Yes, we'll still treat, but the overall care and maintenance, and it's a new way of thinking, and it's okay.
Great, thank you very much, Pat. So we do have a few minutes left, so I'd like to open up now to any questions that any of you on the line might have for our panelists. And again, it's *2 to unmute your line. You can feel free also to type your question into the chat box.
Sometimes it's a lot to think about, Tracy.
It is a lot to think about.
This is Sarah. And Charlie, I was wondering, you alluded to it a little bit when we talked about tools and resources, but can you talk a little bit about what the process was for getting the payment system set up? I loved your visual of the model of the care that you want to provide, but I can't imagine that it was a quick fix for getting the payment model aligned with that.
No, I think several things happened. One is our Medicaid program in New Mexico switched to what they call centennial care in their waiver. And in that, we were able to work with the director of Medicaid and some staff to talk about prevention and management payments, not just diagnosis and treatment. So the healthcare system is prevention, diagnosis, treatment, and management. We pay very well for the middle two, diagnosis and treatment. We pay nothing for prevention and management. And so we were able to talk about making it a responsibility of the MCOs to do the full spectrum of care, including prevention and management in different ways. And as a result of that, we were able to partner with one of the MCOs, medical directors, who was a graduate of the University of New Mexico, and work on this care coordination. The high-end piece was the lowest hanging fruit. And from that, and once we started realizing the savings, and we only measured savings in pharmacy, ER, and inpatient. We didn't measure savings in lab and x-ray and subspecialty physician fees. So that $4 savings I was talking about is light, And once we were able to prove that, then sort of the next level discussion we started having was upstream, and how can we work on keeping people from entering the level 3 or the high cost. And that's when we started designing the level 1 and 2 piece. So it was over a period of time. It was a collaboration between University of New Mexico Office of Community Health and our organization, and initially Molina Healthcare, and then now Blue Cross Blue Shield is a major financer of the pilot. We're going to do 10,000 Medicaid patients, 8,000 in Albuquerque and 2,000 down here, and see how it works in all 3 levels in terms of not just cost but outcomes. and it's been, we actually had the plan approved twice by the legislature, 2 years, had a different name then, but we were trying to model it in one county, sort of carve out a county and treat all Medicaid patients with this model. And the legislature approved it twice and the governor vetoed it twice. So now we have gubernatorial support for this particular pilot. We've got Medicaid on board, obviously, and I think it's been a long process, but a good one, and I think it's going to serve well. It's going to be a replicable, easily replicable model. It's not a mystery.
Great, thank you very much.